Hello, and welcome to the CAP Today webinar for Tuesday, October 1st. I'm Bob McGonigal, and I'll be your host, and I'll moderate a question and answer session after our formal presentation. Today's webinar is both timely and very important, and the title of the webinar, of course, is PD-L1 in gastric and esophageal-gastric junction carcinoma. This important webinar is made possible by a special educational grant from Agilent DACO, and we want to acknowledge that support and thank them for their help in allowing us to present to you this very important program. Today's speaker is Dr. Mar Iglesias Coma. She's the head of pathology at the Hospital del Mar in Barcelona, Spain. And so if that's not enough to make you eager to hear her and envy her location, I don't know what is. And before we begin, let me just give you a few housekeeping tips that I hope will enhance your enjoyment of today's program. We often recommend that you refresh your browser. We do have live help at all times with operators throughout today's webinar. You'll see in the bottom right-hand corner of your screen a toll-free number for you to call, 858-345-5916. They can help you with any computer problem or audio problem. And also, if you see the box below the slide there, labeled Q&A, you can put technical issues into the slide there and we'll jump on them right away. Of course, the question and answer box is principally for your comments and questions for Dr. Coma, which we will get to at the end of the webinar today. I want you to know that we'll be posting the full slides and audio of today's webinar at captodayonline.com in about a week. It's an excellent way to review and share what you're about to hear and see today. You can expect some follow-up emails from us and from Agilent DACO. And finally, I need to let you know that CAP Today does not endorse any products or services that may be mentioned today. My own comments are purely personal, not to be taken, obviously, as policy of the CAP Today or the College of American Pathologists. And so that we're going to go ahead and begin today. As we sometimes do, we're presenting you a very special pre-recorded lecture from Dr. Coma. She's going to rejoin us in live time to answer your questions and comments at the conclusion of this pre-recorded section. So let's go ahead and play that now if we can.
Good afternoon to everybody. I am Mar Iglesias, and first of all, I would like to thank Agilent and CAP Today to bring me the opportunity to be here with you. It's a pleasure and an honor. And today I'm going to talk about PD-L1 in gastric and gastroesophageal carcinoma. These are my conflict of interest, and this is the agenda for today. First of all, I will give a short introduction, and then we will talk about indication and go direct to CPS determination. As you all know, gastroesophageal tumors are a global health problem. Gastric cancer is the 5th most common tumor, but also the 4th cause of death from cancer. You also know that there's a great geographical variability, and also that gastroesophageal adenocarcinoma are increasing while gastric cancer are decreasing. As you may also know, in gastric adenocarcinoma, we are moving from a histological classification, the Lauren classification, to a description of 4 molecular subtypes. This classification is based on massive transcriptomic and epigenomic analysis, and there are these 4 main groups. The most common is the chromosomally stable group. It represents more or less the 50% of the cases, predominates in the gastroesophageal junction, and correlates with the intestinal tubular subtypes. Those tumors used to have tyrosine kinase receptor amplification like HER2. The second group I want to talk is the genomically stable. It represents more or less the 20% of the gastric cancer. It's more frequent at younger ages and correlates with the diffuse subtype, and is characterized by alteration in CDH, ROA, and also clotting. The other two groups, Epstein-Barr virus and MSI group, are really important in this area of immunotherapy. The microsatellite instability group represents more or less the 22%, is more frequent in women, and is localized in localized tumors, has a better prognosis, and presents hypermutations and also alterations in DNA repair genes like MLH1 methylation. And finally, the Epstein-Barr group represents 10%, is more frequent in fundus and body, and is characterized by overexpression of PD-L1 and PD-L2, and has a significant cellular immune infiltration. In the esophagus, the transcriptomic analysis has shown that the two main histological types, adenocarcinoma and squamous carcinoma, are molecularly different. Gastroesophageal adenocarcinoma is quite similar molecularly to the chromosomal instability subtype of the gastric adenocarcinoma group. And the squamous carcinoma is quite similar molecularly to the other squamous lesions of lung and otorhinolaryngologic area. Moving to the biomarker we should test in every metastatic gastric cancer, I really like this figure. It is very visual, however, it's changing very fast. In metastatic gastric cancer, we need to test HER2, MSI, and mismatch repair genes, also PD-L1. And depending on the case, upon request from oncologists, we will also need to test NTRK fusions. In Europe, we have also a new indication for Claudin 18.2 expression that has been approved, a couple of days ago. So it's not in the future biomarkers, it's already in the ones we need to test. In the close future, we will need also to test FGFR2b overexpression and amplifications. But for squamous carcinoma, the only biomarker that we have nowadays is PD-L1, while in adenocarcinomas of the esophagus, we will need to test the same biomarkers than in gastric cancer. Next, in a very schematic and brief way, I will summarize how immunotherapy works. Until relatively recently, in the carcinogenic process, we only look at the tumor cells, ignoring a little bit the surrounding microenvironment. In the recent years, however, the stromal microenvironment surrounding the epithelial cells has been studied. Multiple cells, fibroblasts, endothelial cells, and inflammation are involved and perform different actions depending on the subtypes. Some functions are anti-carcinogenic, such, for example, the action of natural killers cells, and others are pro-carcinogenic, like actions of M2 type macrophages. Looking specifically at the inflammatory microenvironment, and again, very schematically, they are tumor cells that are able to evade the immune response that would normally destroy them. These tumor cells are able to express receptors that bind to lymphocyte ligands and block these native destructive actions of the lymphocytes. PD and PD-L1 would be one of the mechanisms for evading the immune response. But with immune checkpoints inhibitors, in the context of immunotherapy, it would block the binding of these receptors and ligand, leaving the lymphocyte at destroying the neoplastic cells. This would be the ultra summary of immunotherapy action. Let's move to the indication of the immunotherapy, specifically for gastric and gastroesophageal carcinomas. I will talk about three clinical trials very briefly. The first one is the Checkmate 649. In this, a study evaluates nivolumab in first line in advanced metastatic HER2-negative disease. The population has 70% of gastric adenocarcinoma, but also a small percentage of gastroesophageal neoplasias and also distal esophagus adenocarcinoma. In this clinical trial exists 3 arms of treatment, and the main objective is overall survival, also progression-free survival regarding CPS higher than 5. This is a really positive study for primary endpoint at 3-year follow-up with a significant increase of overall survival in all the patients and also in patients with CPS higher than 5. You can see in this cohort that the hazard ratio is 0.70. That's why this treatment, this clinical trial with these positive results, has a FDA approval in all patients, but also a EMA in Europe approval with patients with CPS higher than 5. The second clinical trial I would like to talk is the Keynote 859. It's also metastatic gastric disease in first line. It has only 2 arms of treatment and stratificates the patient depending on CPS, higher or low than 1. The objective is overall survival. And in that case, also is a positive one, is a positive study for primary endpoint with a significant increase overall survival with a hazard ratio of 0.78 in all patients. But as you can see also in the graphic, patients with higher than 1 CPS responds a little bit more, has an increased overall survival, saying that this indication has been approved in Europe only till nowadays. And the last clinical trial is the Keynote 811. Again, is a metastatic disease, gastric cancer, first line, but in that case are HER2 positive cases. There's also 2 arms of treatment with pembrolizumab. The patients are also stratified depending on CPS, and the objectives are overall survival, but also progression-free survival, taking into account also the response. As you can see, the arm with pembrolizumab responds more, complete response or also partial response. And also there are, in the pembrolizumab arm, there were longer progression-free survival and overall survival in all patients, but again, higher in patients with CPS higher than 1. FDA has the approval November 2023 for patients with a CPS higher than 1. Those are more or less a summary of the main clinical trials regarding the determination of CPS in gastric cancer. Let's focus now in the CPS. As you know, there are different ways of determining the expression of PD-L1. Our colleagues that do lung, for example, they will need to determine PD-L1 through TPS, tumor proportion score. Breast or uropathologists also use the immune cell proportion, but in gastric or in gastroesophageal neoplasms, we will need to test combined positive score, CPS. CPS is this mathematical formula. In the numerator, we will include the expression in tumor cells and also in some inflammatory cells. And in the denominator, we will include all viable cells present in the sample. That's really important. You need to know that nowadays The determination of the expression of PD-L1 in gastric cancer must be done with this pharma diagnostic test from Agilent using an anti-PD-L1 monoclonal antibody, the clone 22C3, in Agilent platforms. It's the only companion diagnostic indicated to aid to identify the patients with gastric or gastroesophageal adenocarcinoma for the treatment with pembrolizumab. Now I will explain some slides about the controls. The controls we need to use to be sure that the technique is well performed. It's essential to review the controls, and if unacceptable staining occurs at any of the controls, the patient sample should be considered invalid and the staining must be repeated. First of all, we will need to validate the hematoxylin eosin staining to confirm the diagnosis and tumor types, to ensure that at least there are 100 tumoral cells, and also to have the first impression about the pre-analytics of the samples. Then we will need to do and analyze the cells block controls that are included in the pharma diagnosis kits. There are two cell block, one negative coming from breast cancer, and also a positive one coming from a squamous carcinoma of the lung. And we will need to check the stainings of both of them to be sure that the staining has been done correctly. We will also need to include in-house positive and negative cases. These cases are very important because they will have the same pre-analytics of the case you want to determine. They will help to verify that the fixation method and the epitope retrieval has been effective. The ideal positive case is the one that has from weak to moderate expression in tumoral cells, but also in inflammatory cells. And the negative one is the one with lack of expression. You can also add an extra control, the positive tissue control. This one is to monitor the sensitivity of the processed tissue and to test the reagents. I recommend to use, and also the manual recommends to use the tonsil, because in that you will have a moderate to intense staining in the epithelial cells of the tonsil, but also a weak to moderate staining in the macrophages that are in the germinal center. Now it's time to take a deep dive into the interpretation of CPS. The evaluation must be done by a qualified pathology, and we are trying to becoming. Hematoxylin eosin is recommended to assess the CPS, as I mentioned. And the manual recommends to look first at the sample at 4 or 10x to get a general idea of the PD-L1 expression level. You will see if it's going to be positive, negative, heterogeneous. It's important to look for further. All areas with the viable tumor cells in the sample should be evaluated from all the tissue biopsies included in the slides. We need a minimum of 100 viable tumor cells to be present, to be considered adequate for evaluation. And the manual tells you that if you don't have these 100 cells, you can recut and re-stain another slide to try to get these 100 cells. Evaluation of the membrane staining should be done at 20x, but not more. And again, let's move to the mathematic formula. In the numerator, we will include the expression in tumor cells and inflammatory cells, and in the denominator, we will include all the viable cells present in the sample. Note that if we have a tumor with expression in all the tumoral cells, but also in the inflammatory cells surrounding, the CPS can be greater than 100, but the maximum point of 100 has been defined. Another thing you have to note is that CPS is not a percentage, is an absolute number. And depending on the case, you can have positivity in tumor cells and immune cells, or only in immune cells, or only in tumor cells. In my experience, in gastric cancer, there's more probability to have staining only in immune cells. Let's move to see how is the staining specifically in tumor cells. This can be partial or complete of any intensity when you see it at 20x, and is a membranous staining. Be careful with the cytoplasmic staining. You need to be sure that there's a membranous staining to include it. It could be partial, complete, of any intensity, but membranous. In gastric cancer, you can have more or less two patterns of staining, the lattice or the interface ones. In the lattice, partial or complete staining in tumoral cell nest is the most seen, but this staining is quite infrequent in gastric cancer, and the most frequent is the interface, where you have inflammatory cells on the pushing area, on the infiltrating area of the adenocarcinoma. This is the most common pattern seen in gastric cancer. Both of them are valid. One is more frequent and the other is less. What about poorly cohesive carcinoma? You can have problems with the CPS because sometimes these neoplastic cells has staining in the cytoplasm. So you need to be really sure to see a membranous staining to include it in the numerator. And I also recommend to work the CPS in poorly cohesive carcinoma with a pankeratin in the site, because at the end you will need to recognize the neoplastic cells and you will need to count it to include it in the denominator. You will need also to include in the numerator the viable intravascular tumoral cells if they, of course, have positivity in the membrane. Let's move now to the inflammatory cells that we will include in the numerator. The staining of these inflammatory cells can be membranous or cytoplasmic. Sometimes you've got kind of a punctate staining that is also valid. The only staining that is not valid in these inflammatory cells is the nuclear one. Be careful because you will only include the staining of macrophages and lymphocytes. You won't include staining of neutrophils, eosinophils, and plasma cells. And this could be a problem because, as you all know, gastric cancer used to be ulcerated with a lot of neutrophils, but also used to have normal mucosa, somehow with gastritis, with a lot of plasma cells that also stains for PD-L1. So we need to be sure that we are counting, including only macrophages and lymphocytes. And another point to bear in mind is that we only include the positive inflammatory cells that are close to the tumor. And that's quite subjective. What does close means? The manual has this tip, is very, very useful, is the tip or the rule of the 20x fill rule. That means that if you've got a pushing tumor, you can put the border on the middle of the 20x field, and you will include the positive inflammatory cells that are included in this 20x field. If the tumor grows with small clusters, you will put the cluster in the middle of the 20x field, and then you will include the inflammatory cells, positive ones, surrounding and included in this 20x. This rule is very useful in the routine. And why that makes sense is the biological action of the immunotherapy. It makes sense that you only include the positive inflammatory cells that are close, surrounded, that are blocked by those tumoral cells. Staining in intraluminal macrophages should be also included as inflammatory cells. And if we've got GN cells, positive ones, we also need to include it, but it counts like one macrophage. We must be careful not to include inflammatory cells associated with preneoplastic lesions or normal mucosa. We don't include those inflammatory cells on the numerator. And as I said before, we're not going to include staining in neutrophils, eosinophils, or plasma cells associated with the neoplastic cells. Let's move on to the denominator. Here, we are going to count and include all the viable tumoral cells from all the tissue fragments that we have in the slide. And exists this kind of table that gives information related to the size of the field and the number of cells in each field, depending on the size of the neoplastic cells. But because the tumors are very heterogeneous, I have never been able to use this rule, this table. So I count the viable tumoral cells that must be included in this denominator. And how I do it? I count 10, 20, 30, 40, 60 as 100. Then I've got the estimation of the area that includes 100 neoplastic cells, and I estimate how many 100 cells I've got in this field. In that case is 800, and then I will count the positive tumoral cells and macrophages and lymphocytes in this area, and then I will repeat this sequence in the next field and in the next and in the next to have all the tissue, all the neoplastic cells already count. It takes time. You need to be patient, but we need to do it. We need to count all the tumoral cells in those heterogeneous neoplasia that we have on the routine. It is important to remember that benign epithelial cells and stromal cells that sometimes express PD-L1 should not be included neither in the numerator, or the denominator. They are not needed to be included. And this is just to summarize what we need to include and exclude in the numerator: tumoral cells, partial linear or complete circumferential membrane staining, any intensity, and also macrophages and lymphocyte with membrane or cytoplasmic stainings included or associated within and present in this 20X field of the tumoral cells. And this is also a summary of what do we need to include and exclude from the denominator. All viable invasive tumor cells and metastatic cells is the sample, if the sample is a metastasis. At that time, it's just remember that there are courses online to learn how to determine PD-L1 every month. This is the last part of my presentation, and I would like to talk about some practical considerations. It's important to have in mind the prevalence of each biomarker to know if we are doing right the test. The most prevalent one is PD-L1, and then you will have Claudin, MSI, and the rest. It's important to have that in mind. Regarding PD-L1, there are several practical considerations when you start to determine PD-L1 by CPS. Some are related to biological aspects, other technical assays, logistical aspects, and also practical implications like a cutoff. I will focus only in heterogeneity and reproducibility. PD-L1 is heterogeneous and could be spatial and temporally heterogeneous. Regarding spatial heterogeneity, in this article, they compare PD-L1 expression between surgical specimens and between hypothetical endoscopic biopsies worked through a tissue microarray. They create this tissue microarray, taking samples from the surface of the surgical specimen, like if they were biopsies, and they compare the quantity of sample of biopsies to the expression that they found in the surgical specimens. And the best sensitivity was when they have 4 biopsies. Using fewer surface biopsies decreases sensitivity and the specificity. And in fact, they recommend that in a PD-L1 negative case, if you don't have at least 4 biopsies, you will need to add a comment mentioning that maybe the results of the PD-L1 is not comparable, is not like the one is going to have the entire tumor. It's important to have enough samples to overcome the heterogeneity of PD-L1 expressions. In this other paper, the authors find that there are more or less 20% of discordance of PD-L1 between primary tumor and metastases, and maybe due to primary tumor evolution or even a false negativity in the primary tumor due to the heterogeneity of the expressions. In this other work, they found also heterogeneity between primary and metastatic. Some cases has higher PD-L1 expression in the primary tumor and other in the metastatic side, but also they found differences on PD-L1 expression in different blocks of the same samples of the same patients. So PD-L1 is very heterogeneous. And also temporarily, patients has a diagnosis, then some of them are treated with chemotherapy, and somehow they can get metastases. So there's a treatment in between the primary and the metastatic that's called temporally heterogeneous. And it seems that there is also, in this paper, they found the same level of expression before and after treatment, but they found differences of lymphocytes surrounding the neoplastic cells, differences on the inflammatory population. But in this other paper, they found a difference of PD-L1 expression between primary biopsy and post-treatment metastases, and the concordance was only 63% with a CPS higher than 1, and of 75 if the cutoff is 10. In this other paper, they found somehow also heterogeneity, maybe a little less. They found heterogeneity intra-block, intra-case, and mostly between primary versus metastatic. Is not that bad comparing to the other papers. And they mentioned that PD-L1 need to be performing by qualified pathologists using specific algorithms to try to overcome this heterogeneity in the results of PD-L1. And to conclude this webinar, I would like to talk about the reproducibility of PD-L1 determination. In these papers, the authors scores 100 cases for CPS, 22C3 and 28A. The 12 pathologists are specialized in biomarker testings. Then they calculate, they determine the CPS, and then they took a 2-hour course, online course, and then 2 weeks after, they reassessed the 100 cases, but also they counted the PD-L1 positive tumoral cells and positive inflammatory cells from 35 cases. They analyzed the inter-observer variability before and after this 2-hour training. And they found a quite low inter-observer agreement before and after treatment in 28 assay and in 22 C3 assay, quite low. And the possible confounders that we can have when we determine CPS are ambiguous identification of positive stained stromal cells, somehow fibroblasts can stain and you don't know if you are looking at inflammatory cells, weak or variable intensity stainings, difficulty also distinguishing membranous tumor staining from cytoplasmic tumor stain, and also countering and crouching device that biopsies have. All this can make difficult and poor reproducible the PD-L1 CPS staining. But on the other hand, and to end with a better taste in our mouth, this paper also evaluates the inter and intra-observer reproducibility, but after a 2-day course, face-to-face with a self-assessment, an intense course. And they found a quite high level of agreement. And they underlined the importance of this 2-day face-to-face course to reduce and to increase, the reproducibility on the CPS scoring. And I think I have covered the most important aspects of PD-L1 determination. I hope it will be useful for your daily practice, and thank you for your attention. I will take questions. Thanks.
Thank you. Thank you very much. Behind that question, of course, I'm sure you've heard it before, is how receptive have most pathologists been to appreciating the difference in assessing the CPS scoring in gastric and esophageal-gastric juncture carcinoma, as opposed to much better known carcinomas, obviously referring to breast?
I don't know if I have understand the question. Can you repeat, please? Sorry about that.
I'm just saying, this question I'm sure you've heard several times before,
Oh, yes.
have you not? Okay.
Oh, yes.
And
yes, of course. Because TPS is easy and CPS is difficult and we need to learn, but I think it has a biological and clinical importance.
very good. That's very important to understand. Now, obviously, many people are interested, and I'm sure you are as well. So I'd like to get your thoughts. Do you currently have any software available to help you in scoring PD-L1 staining?
They are performing through artificial intelligence algorithms, but they are, I think, almost finishing the validation. In fact, some of these days, a company will teach me how it works. So I think it's not yet fully validated, but is it going to be soon? And that will make our lives a little bit easier. They are already commercialized algorithms to TPS, for example, for lung, PD-L1 in lung, But
Yes.
yes, I mean, last week, a company told me that they already have an algorithms for CPS and seems is working, but I wanted to try it, and also they will need to completely validate. So the answer will be yes in the close future.
Very good. I don't want to force you to stare into your crystal ball, Dr. Coma, but would you imagine that there'd be a robust helping and scoring, say, within the next year or so?
I think sooner. I think sooner.
You think sooner, okay.
I think sooner, yes, because it's not only one company. I think there are a couple of companies that already start to talk about these CPS algorithms.
Thank you. Thank you very much. I'm interested now in taking just a little different tact, and we have something that comes right up here, and that's this general question about tumor agnostic indications for immune checkpoint therapy. Are you doing any of that kind of work towards tumor agnostic indications or HER2 assessment in gastric tumors, which we also know has been reported?
I'm not sure I understand the questions. It for diagnostic. In Spain, we need to perform PD-L1, not in all the patients, because our indications are a little bit more restrictive. In fact,
Okay.
I would like to announce, because now we've got indications in Europe that we need to test CPS1, but you now don't need to do it. And in fact, I would like to announce that last week, FDA advisory panel met to discuss and vote on restricting the use of these immunotherapy agents, nivolumab, pembrolizumab, and tislelizumab, for patients with PD-L1 expression of 1 or greater. So now I explain you've got only one indication that you will need to calculate CPS, but probably you will have more indications and you will need to determine more CPS in other indications.
Very good. Thank you so much for that.
And for example,
go ahead, please go ahead.
Sorry. For example, we work in a university, in a hospital, and for academic purposes, and also because most of the patients of gastric cancer are going to be metastatic at the moment of the diagnosis, we perform all the biomarkers in a reflex mode with every gastric cancer diagnosis. And we do HER2, PD-L1, mismatch repair genes, and Claudin 18.2 in a reflex mode. We are really lucky because we are able to do that. And then we present the results in the multidisciplinary tumor board with the results of the biomarkers, so we can decide the better treatment for each patient with all the information.
Thank you. Thank you very much for that answer. I did want to ask you, how important are all the basics of the tissue processing for optimizing the CPS counting? That is to say, a tissue fixation, proper staining, proper sectioning. Was there any changes that needed to be made, or did you have to tweak or slightly alter certain processes to get the optimal result for CPS scoring?
I mean, we need to be careful with every step of the pre-analytics of the sample, but we will need to be aware and be careful with that for HER2 testing, for mismatch repair. So it's the same pre-analytic. And we need to be very careful with the fixation time. I think the guideline for HER2 that has been written in 2016 help us because it's are the same rules for PD-L1. And also the amount of biopsies that we need to ask to our endoscopies, because we saw that PD-L1 is also heterogeneous. Depending on the paper, you need between 4 and 6 fragments to overcome this heterogeneity. So I think that the pre-analytics and also the samples that we need for HER2 are the same for PD-L1, and it helps us. The pre-analytics is super important to perform and determine every single biomarker.
Thank you very much. Let me ask you a question now about your oncologists and surgeons. Many of your colleagues in North America report that many surgeons and oncologists become so excited about the immune checkpoint therapies that they want to rush to get those to the patients. And as you may or may not know, of course, there's many patients who know about these things and are very excited about them and ask about them. Do you have a similar experience in Spain at the hospital where you are?
Hospital del Mar is not a big hospital, and we work really as a team. So we discuss each patient in the tumor board, and of course, oncologists and surgeons wants to know, because the oncologist and myself, we talk, okay, Laura, this CPS is 15, and oncologists then ask, okay, so what's a CPS? So what did I do? So I gave a talk about biomarkers, about the importance of the pre-analytics, about the importance of the fragments of biopsies. I think teaching each other and share knowledge between the colleagues in the multidisciplinary team is very important. And also the subjectivity and the moderate reproducibility. I think it's important to mention the good and the bad things.
Very good. Thank you. Thank you. I know it's fairly early innings with the new approval for Enhertu. Do you have any yet experience, you or your colleagues, because it was recently approved, at least in the States, for HER2-positive tumor agnostic indications?
No, not yet. In some specific in some specific case, like I don't know, cholangiocarcinoma, sometimes they ask me to do HER2, but in some specific case, we don't have still this indication in Europe. And also the HER2 low will probably arrive, but we still don't have experience on that yet.
Okay. Thank you very much for that. And I think we will, with that, give you the very last word. Dr. Mara Iglesias Coma, I want to thank you so much. This has been a wonderful presentation. For those in the audience asking questions, yes, we're going to post this presentation and the Q&A in about a week at CAP Today online. So now as I wrap up, obviously I want to thank Dr. Mar Iglesias Coma, coming to you from Barcelona today, both on tape and live with me in the question and answer. It's been a wonderful pleasure, and I'm sure everyone will like to review this and share it with many colleagues. So thanks to you, Dr. Coma. Also, I want to thank Agilent DACO for their educational support of this program. It's very important to us, and we acknowledge their help and our gratitude to them. Finally, I also, as always, I want to thank all of you participating with us today. It's a great large group, as I would imagine it would be, This has been a wonderfully enlightening program, and I want to thank you for taking time out of what is, I know, a very busy day to join us. We're always grateful when you come, and we hope that we're providing programming that is important to you and that you enjoy this format. So with that, once again, let me wrap up. Thanks to Dr. Iglesias Coma, thanks to Agilent, and thanks to all of you. And with that, I will bring today's webinar to a close.